Clerking patients. Clerking patients is something you're probably familiar with doing through medical school, but now this is where you're the doctor, you're the one doing the initial clerking.
Two great sources of information that you'll be able to acquire before history taking is usually a green piece of paper from the ambulance on admission. This can surprisingly contain a decent amount of information written by paramedics, including the patient's observation at the point of healthcare interaction. Now that everything is more accessible online, it's also worth looking at the patient's previous admission history on the hospital system. So this will give you a bit of a gauge of the patient's comorbidities, as well as a useful drug history if patients fail to recall on your clerking.
When seeing patients on the wards, we have the luxury of reviewing notes and checking recent blood tests, pathology and lab results, as well as any available imaging.
What I try to do before clerking a patient is gather as much information as possible. So looking at their recent discharge summary or patient record to get an idea of what their comorbidities are. If they've already had any tests done, then just get those results up. So then you're going in with a bit of information and actually can make your clerking quicker, because you can say, I can see you're on ramipram, bisoprolol. Can I check those doses are correct? Is there anything else you're on? And it just makes it a bit quicker rather than getting them to recall every single medication they're on. Some of them will bring in lists. That's really helpful to just get hold of that, borrow that, write that down.
This is by far the most important aspect of the clerking, because it will dictate your line of inquiry and determine what examination and investigations are appropriate in order to narrow down your differentials. During stressful and busy times, there may be some things that are missed out or even misinterpreted in the previous A&E clerking, so make sure your history taking is accurate and focused.
With everything, be systematic, start with open questions and then go to closed questions. You'll find if you're on acute medical ward, they may well have a pro forma that will just prompt you for each thing, but it's just going through your standard history.
So when you're seeing a patient in A&E, you may be given a handover. For example, this is Mr. Jones. He's come in with a 3-day background history of abdominal pain and vomiting, and we've done a basic blood test, we've taken some observations, and we've requested some imaging. And first checking the patient's identity, of course, name, the date of birth, hospital number if they have one, and a wristband, hopefully, if they have one on. Checking that the patient is comfortable with whoever else may be in the cubicle, if they're a family member or a friend. Note down their name and their details as well. Then check the presenting complaint of the patient, for example, abdominal pain. And then we go into the history of presenting complaint, the reasons why they've come into hospital, and then as you would go through the past medical history, the past surgical history, drugs histories, checking the allergy, over-the-counter, herbal medication, if there's any medical conditions that are in the family and that may be relevant. Social history, checking their smoking, their drinking, recreational drugs, their home and social environment, what sort of accommodation they live in, what their normal activities of daily living are like. Do they need any support? Do they have any family members? Are they working? Are they employed? Do they have any dependents? What their main social, financial and psychological forms of support may be. I would do a very brief systems review when I ask them about brief general symptoms such as chest pain, shortness of breath, abdominal pain, any neurological symptoms that they maybe have, establish their eating and drinking habits, their bowel and bladder function. By this time, you should have a reasonable idea of why they're in hospital, why they're admitted, and you can finish off your history by asking any relevant questions. So they may be obs and gynae related, they may be psychiatry related, and if you're seeing a pediatric patient, you may be taking a different approach and asking any relevant history questions, for example, immunization status, and checking the growth charts or the red book if they have it and if it's appropriate.
If you're taking a focused examination, for example, a cardiovascular examination on a patient who presents with chest pain, don't feel rushed and just take your time to ensure that you do a proper examination to ensure the accuracy of your findings. Think fast, act slow. I would split these into 4 categories in this order. First, you have bedside investigations like ECG, then point of care tests that give you near immediate results, such as blood gases, blood glucose. The third would be blood or laboratory investigations that take longer to produce results, and then finally imaging. Tailor the investigations relevant to your differentials. One of the most important investigations that you'll encounter frequently would be blood gases. They're quick to get and can tell you a lot about the patient. Acid base, metabolic, respiratory compromise, electrolyte deficiencies, blood sugar, hemoglobin, any evidence of organ damage in terms of rising lactate. So please take your time to carefully and properly look at every single result on the blood gas and act as appropriate.
Come up with a plan, come up with what your impression is. It can be query, that's okay. And come up with a bit of a plan, and then you'll get it as an F1. Normally you have a senior coming to review that patient fairly quickly. If you're worried about a patient, make sure that review is sooner rather than later. If the patient's quite stable, then obviously you can go on and see another patient in the meantime.
If there's any doubt about what to do, or you're not sure of anything, don't be afraid to ask for help. Be that your F2 colleague, your core trainee, or your registrar. Healthcare is multidisciplinary and not one-man band, especially during this current climate.